Hello everyone, this is Dr. Pruitt. Welcome to this week's EKG. I'll give you a second to take a look at this one. I don't know about you, but my first impression when I saw this one was like, oh my goodness, this patient looks sick, right? Without even knowing what was going on, I had an instant suspicion. So I hope, just like me, by the end of this session, you've burned this one into your head and you recognize it instantly and know what you need to do. So the setting for this case is a 63-year-old female who has not been feeling well for the last week. And as a consequence of feeling weak and tired and just not wanting to get out of bed, she's missed her last 3 dialysis sessions. Now this should set off some red flags in your head. We proceed just like normal. We get our set of vital signs, and here's what you see. You see a bradycardic patient. You see a bradycardic patient who's hypertensive, satting 88 on room air with a pretty tachypnic respiratory rate and a little bit of a fever. So these are concerning vital signs. She's hypertensive, she's bradycardic, she's hypoxic with a fever. She's got a lot going on, and I can tell you, probably just looking at her from across the room, she does not look very good. So this is the EKG that we get, and we start the same way just like we do every time. We start with the rate. And just looking at this, it looks slow, and this one's going to be a little bit hard to determine because I don't really know where the P waves are, but we'll start. Computer's telling me it's 49. To the general glimpse, it also looks like it's slow. I'm going to try to find a QRS vector that matches up with a thick red line, and then we'll count down from there. The one that looks like it's the easiest to see is probably right here. So we'll line this one up. We'll line this one up. We'll say 300, 150, 100, 75, 60, 50, and then 40. So we're somewhere between 40 and 50 to the next kind of depression here. I'll agree with the computer. We'll say this is a rate of 49. Moving on to our rhythm, again, going to be a little bit challenging because this one looks so atypical, but we'll do our best. The first question we always ask is there P waves? Do I see them before every QRS? And in this particular instance, I try to look at lead 2, where I normally have some good luck finding P waves. I'm not seeing like distinct P waves here at all. I'm looking in 1, 3. Do I see them anywhere? Maybe one here, but I don't know. Is that a T wave? I'm not sure. Moving across the precordium, again, I just don't see distinct P waves. And I think this rhythm would be consistent with an idioventricular rhythm. So this is we'll do the QRS in a second, but it looks wide to me. It's very slow, and there's no P waves. This suggests to me that maybe that sinoatrial node isn't working. We know that rate is usually 60 to 100. If the sinoatrial node's not working, the AV node takes over, and you don't see P waves. But here, I think this rhythm may be generated from the ventricles because it's so wide, it's so slow, and I don't see P waves. So I'm going to call this idioventricular. The next question we ask when we're looking at our rhythm is it regular or not? And again, very challenging because this looks just a little disorganized here and not really like anything I'm used to having to interpret. And so I see like a little bit of distance. Maybe if this is a QRS vector here that's wide, an interval here, but then I have a long interval, and then it's short again, and then long, short, long, short. But here it's like looking a little more regular. So I would call this an irregular idioventricular rhythm. Since I don't see P waves, I can't really tell if the QRS is normal or the QRS complexes are at a regular interval. Irregular idioventricular rate. Next, we move to our axis. Again, a little bit challenging because it's not like what we're typically looking at, but we can look at lead 1. We can look at AVF. I would say that the majority of the QRS vector in lead 1 is up. Remember, that's your left thumb. We have a left thumb up. AVF is our right thumb. I would call this mostly up. I don't see anything that's mostly down, so I'll give it a 2 thumbs up. I'll call it normal axis for now, but again, challenging to interpret. And here's where we start to get into what's really wrong with this patient. When we look at our intervals, the QRS complex is incredibly wide. So if you remember, 120 is normal. We're at 174. Very wide QRS, very, very wide QRS. And as we look at our QT, again, we know with bradycardia, our QT tends to prolong. And then with a wide QRS, our QT tends to prolong. So I'm not surprised that we also have a long QT. The computer's reading this at 493. I wouldn't be surprised if it's even longer. But the QT is probably long because our QRS is very wide. So we have a very, very wide QRS. As we move on to finish out our interpretation, we're looking at our ST segments. And it is, again, pretty difficult to interpret because we don't have our normal P waves. It's hard to find a baseline. You could think, and I don't think you'd be wrong, that maybe there's a little ST elevation in these precordial leads. But I see a baseline there. Inferiorly, where I like to start, again, like I think I have a pretty good baseline here. If I'm even looking at like a peak QRS complex. And so I don't see any big depressions or any kind of things that would be reciprocal. I think you could make an argument that maybe there's some ST elevation here, but when I look reciprocally, there's no big depressions. So I think whatever is happening with these T waves is probably a consequence of the other problems this patient has going on. What does stick out is the very wide QRS with like kind of a big, powerful repolarization, right? Those are big waves that are starting to look very wave-like, right? And so to me, this suggests peak T waves, bradycardia, idioventricular rhythm. I hope you're with me in thinking of hyper K. I would like you to burn this 12 lead in your head. What's difficult about this is that it's bradycardic, right? And it's going to be very tempting to go down your bradycardia algorithm with this patient. You have a sick patient, doesn't look well, is febrile, hypertensive, hypoxic, bradycardic. It's going to be tempting to try to pace this patient because it looks like a scary 12 lead. But if you think about it, if you go down your bradycardia algorithm, you're going to miss, and she's never going to get the treatments that she needs to treat her hyper K. And so if you can see how this is starting to turn into a sine wave, even the computer's helping you here, it doesn't always do that with the interpretation. But if you have a bradycardic renal failure patient, you need to think hyper K. The causes of hyper K are, number one, renal failure. We see this the most, and you've got to think about it in your renal failure patients, especially when they've missed dialysis. Their kidneys don't work. They can't waste potassium like they're supposed to. It builds up in their blood and it can get toxic for their heart. Other patients you need to think about it with are crush injury. If they have any mechanism that will be bursting cells and that potassium that lives inside the cell is released to outside the cell, that's a patient you need to think about hyper K. And then acidosis, that weakens the cellular membrane and also lets potassium leak out. And so those three patient populations you really need to think about hyper K. Always get a 12 lead. What's happening here is that the membrane is stabilized by the cross flow of sodium and potassium. And in normal normokalemia, your T wave is made of potassium. And so if you have a normal level of potassium, you have a nice strong T wave, that's your repolarization. In moderate hyperkalemia, you have just enough potassium building up outside the cell that's very anxious to get in, and there's a lot of energy. Everything's still pretty organized, but there's a lot of energy for that potassium to rush in. It has a high resting potential, which is that energy wanting to rush in, and then really that velocity as they rush in is high. And so that's where you get your peaked T waves. But as the hyperkalemia gets more and more severe, things get very disorganized. And the potassium can't rush in like normal. The membrane is not as stable as normal. And what you start to see is this development of a sine wave. There's no more really regular depolarization, repolarization. You get a reduced conduction velocity. The cell is really pretty refractory to trying to depolarize because there's just so much potassium everywhere. It's running amok. The cell is not like a nice organized flow of positive charges. And then you get your conduction blocks. Bradycardia is really a very late sign of hyper K. So if you have a bradycardic hyper K patient, you need to think that they are peri-arrest and you need to treat them aggressively. And don't get fooled because it's going to be tempting, I promise, to go down your bradycardia algorithm, but you need to recognize this and give them the treatments that they need because neither one of these treatments are in your bradycardia algorithm. So what we give them right away is albuterol. It's really easy to throw that neb on there, get that on as quick as you can. And what this does is it actually moves potassium into the cell where it needs to be. This is your only med that you can give in the pre-hospital setting that is going to move potassium out of the blood where it's toxic into the cell where it's supposed to be. So give this quickly, and you can give up to 15 milligrams by a nebulizer. The next thing you want to give as quickly as you can is calcium. Now, it's important to know that calcium doesn't do anything to move potassium at all. What calcium is going to do for you is stabilize that cardiac membrane. So you can tell that EKG, it looks unstable, right? And so what calcium is going to do is you can actually watch this happen. It's going to narrow your QRS. And so if you have a hyper-K patient with a wide QRS, if their QRS is greater than 120, and ours was like 170, right? That's a very, very wide QRS. That patient needs calcium because it's going to stabilize the heart, and you can give that while you're giving your albuterol. Now, it's important to get a line on these patients, and inevitably they have very tough access, right? Like our dialysis patients are some of the hardest ones to start IVs on. I know it's a little uncomfortable, but if you see this kind of 12 lead, consider starting an IO so you could give them that calcium and help stabilize that heart because they could be peri-arrest. And so this is another look at severe hyper-K. I hope you can burn this one into your head, and the next time you see it, you'll recognize it and be able to treat it effectively. This is absolutely where you have a chance to save a life.